Well, good morning, good afternoon, good evening, everyone here. Welcome to the first NEMUS webinar of 2015. And well, we are almost finishing the first month of this year. It's impressive, but actually I can still hope, wish you all a good 2015. Today we have actually a topic that is not exactly related to PrEP. It's focused on the guidelines of post-exposure prophylaxis for HIV, and concretely, it's a presentation about the recently released recommendations for a public health approach concerning post-exposure prophylaxis. Now, as you all know, PEP has been used. We have been using PrEP for a longer time, although it was never the focus of a randomized control trial. But as far as I know, but definitely it's a strategy that has been used for several people, and we'll be able to hear about it from Dr. Nathan Ford. Nathan currently works in the HIV department at the World Health Organization. He has worked with the Médecins Sans Frontières since 1998, supporting operational research and medical advocacy. He holds a degree in Microbiology and Virology from Warwick, a master's in Public Health and Epidemiology from Cape Town, and a PhD in Clinical and Public Health Epidemiology from Vancouver. He serves on various editorial boards, including the Journal of the International Society and Conflict and Health. Areas of concern he focuses on include evidence-based humanitarian action and simplification and adaptation of HIV/AIDS care in resource-limited settings. So, webinar for 1 hour. As you know, Dr. Ford's Nathan will be talking for a while, and then in the time we have left, probably during his presentation, you may write your comments or questions in the chat window on the right-hand side, and we'll try to answer. He'll try to answer those at the end. We'll be recording this session, and it will be released as well in our YouTube channel as soon as it becomes available. So thanks, Nathan, for being here. Are you ready to speak now?
Yes, I am. Can you hear me okay?
Okay, yeah. I think if you can speak a little bit louder, that would be better. Okay, so Nathan, thanks very much for being here, and the floor is yours.
Okay, so thank you very much, Carlos, for this invitation to present, and thanks to all of you for attending. As was said, this is going to be a summary of the process by which we developed the latest PEP guidelines that were released in December 2014, so they're less than 1 month old, or just around 1 month old. I hope you can all see my screen. Is it okay?
Yes.
Okay, great. So I will move straight forward to the next slide. As you all know, PEP is a widely accepted intervention. It's been around for 20 years. As has been said, it's not based on randomized trial evidence because of the ethics and design complications of designing randomized evidence around exposure to HIV and then post-exposure prophylaxis. But the evidence for PEP came from animal studies and one case control study showing that it was effective in reducing the risk of HIV acquisition, and I'll go on to that data in a minute. So it's been widely used despite having limited evidence supporting efficacy and even more fragmented evidence supporting the choice of drug regimen, and most guidelines until the WHO guidelines were developed did not develop guidance based on systematic reviews of the evidence. They rather relied on expert opinion and the cumulative adaptation of guidelines that were already existing. WHO, in order to produce guidance, has to do systematic evidence reviews and convene an independent representative expert group to review the evidence in order to make recommendations. So this was the first attempt to develop a evidence-based process in order to develop PEP recommendations. We also know that from observational studies that despite being very, very widely available and accepted, uptake and completion rates for PEP are not optimal. There's evidence from studies that were systematically reviewed for this guideline process that suggested completion rates of around 50% in general. So 1 in 2 people who start PEP don't complete it. And it was with that understanding that the guidelines wanted to not only be evidence-based, but they wanted to build on the public health approach that has informed WHO's antiretroviral treatment guidelines, which is to say to make the intervention as simple as possible for providers and patients in order to be able to increase uptake and maximize the chance of completion rates. The last WHO guidelines were produced in 2007. They were produced together with the International Labour Organization, so they only really focused on one exposure, occupational exposure, and they also only focused on adults. They recommended the antiretroviral drug AZT as the preferred drug as part of a PEP regimen, because AZT was widely accepted for treatment at the time. But since that time, since 2007, international and national have shifted towards preferring other drugs than AZT due to tolerability concerns. So we knew we needed to update the guidelines because new drugs were available, because evidence was showing that the intervention was not working very well, and because there was an inconsistency between the intervention that was recommended for PEP and the drugs that are recommended for treatment and the drugs that are recommended for PrEP. So for very resource limited settings, this poses a problem of procurement, management, training and distribution at the primary care level. So another important principle for WHO is to harmonize recommendations for antiretroviral drug use as much as possible across all these interventions. We now have 4 interventions to prevent HIV transmission using antiretroviral drugs. We know antiretroviral therapy works effectively. We know for treatment, early initiation of antiretroviral therapy, PMTCT, PrEP and PEP. And if we can harmonize as much as possible the way in which we use the drugs for these 4 different interventions, it will certainly make things simpler for procurers and provide increase uptake across all interventions. So we undertook a range of systematic reviews. I should finally say that we also wanted to get away from having multiple guidelines for multiple exposures. Traditionally in the field of PEP, different guidelines were produced for occupational exposure, non-occupational exposure, and sexual assault. And different guidelines were also produced depending on age, so PEP guidelines for adults, PEP guidelines for children. We wanted to produce a single guideline that went across exposures and populations, and by doing that, we wanted to focus on risk rather than exposure type. We wanted to align as far as possible the recommendations for adults and for children, recognizing that one can only go so far due to the limitations of medicines that are available, and I'll get onto that later in the presentation. And we wanted to simplify as far as possible the approach to prescribing, keeping in mind the poor completion rates for PEP. So we undertook a range of systematic evidence reviews. We systematically reviewed the evidence from all animal studies to clarify the effect of PEP prevention on the basis of these animal models. We systematically reviewed completion rates from observational studies. We, from that cohort of observational studies, we tried to determine whether there were differences in completion rates and discontinuations due to toxicity associated with the use of different drugs. We also reviewed the evidence on interventions to improve adherence to see whether there was any evidence of using particular interventions to maximize completion rates. We complemented that systematic review evidence with a series of other evidence reviews, notably the values and preferences through qualitative survey of providers and end users of PEP. We gave thought to the feasibility of using different interventions. In the case of drugs, that usually means favoring drugs that are widely available and for which there is experience over drugs that may have a clinical benefit but are too expensive or not yet on national formularies. And cost, similarly, we wanted to give consideration to using drugs that are affordable and available in most resource-limited settings. To note that WHO's guidance is global in nature. We do not set out to produce one set of guidelines for wealthy countries and another set of guidelines for poor countries. Absolutely not. But we have to be aware of the environment in which the majority of people are living, and in resource-limited settings that means health providers that may not be as adequately trained and drug supply that may be more limited than is seen in resource-rich settings. So to summarize some of the data from the evidence reviews, some of these slides are quite but we have submitted all of the evidence reviews for publication, and there will be a special issue of clinical infectious diseases coming up in the next few months. So the full data set and the more complete information will be available shortly, and we will put that on the WHO website as well. So we reviewed the data from the animal studies, and there were over 20 animal studies over the last 20 years in which PEP was used as an intervention compared to placebo or control, and the effect size of the reduction in new infections was measured. And we can see from those animal studies that PEP gives around 90% efficacy in reducing infection. That's the graph on the left-hand side. We used what's called a cumulative meta-analysis, in which each new study that comes along adds to the data of the pooled estimate of the information that already exists. And using this approach, you can see that already by 1997 we had enough information to show that a statistically significant benefit of PEP, and all subsequent studies have served to improve the confidence around the effect size of the estimate. To note as well that the later studies used improved drugs with better efficacy, and in the case of humans, better tolerability. So tenofovir started to be used in PEP in animal studies from 2000 onwards. What you have on the right-hand side is a meta-regression looking at the effect of the timing of administering PEP on the rate of seroconversion. And although this data is fairly fragile because the sample size is relatively small, there is a statistically significant relationship between timing of PEP and seroconversion. So this is consistent with the clinical recommendations that have always been made, which is one must start PEP as soon as possible, and it just provides additional evidence to demonstrate that relationship. To note that many in the guideline committee were quite enthusiastic about whether we could use this evidence to finally provide a definitive cut-off point by which, from which point on PEP is no longer considered effective. Clinicians struggle with the fact that guidelines may say you must administer PEP within 48 hours, but patients present maybe at 60 hours or 72 hours or 73 hours, and they would want to know whether there's any benefit of providing PEP beyond a determined cutoff point. Unfortunately, these animal data do not allow you to make such a binary conclusion. We can just simply reaffirm that the sooner the better when administering PEP. So the second review we did that I've already alluded to, the proportion of individuals completing PEP by population. This was published in AIDS a couple of months ago, and the evidence shows that irrespective of exposure type, whether you're exposed through occupational or non-occupational or sexual assault, completion rates are low. They are higher for occupational than sexual assault, but across all exposure types, less than 6 in 10 people are able to complete the 4-week duration of the intervention. Key populations are at risk of having lower completion rates than the general population. There's very little information on female sex workers, better information on MSM, and it's notable that MSM actually have higher completion rates than the general population, and I'll get on to what that says about the potential relationship between PrEP and PEP as complementary interventions, as two sides of the same coin, a little later in the presentation. And by age, we see that adolescents do worse than the general population. So when we consider the people we're confronted with in the clinic who are eligible for PEP, we need to be particularly concerned about certain key populations and adolescents as being at high risk of not completing. And this evidence is echoing what we already know from antiretroviral therapy. So the first recommendation we developed following that knowledge around the poor completion rates of PEP was a best practice set of recommendations. So it wasn't derived directly from the evidence, but it was complemented by the evidence. And we recommend that PEP should be offered and initiated as early as possible to all persons with an HIV exposure, and ideally within a window of 72 hours. So the offer underscores the voluntary nature of the intervention, and the early as possible underscores the fact that we really should be doing everything we can to get people who are eligible for PEP on PEP, provided they agree, as soon as possible. Eligibility assessment should be based on HIV status of source whenever possible, recognizing that this is not always possible, and one should consider background prevalence and epidemiology in order to come up with a local calculation of risk. Exposures that may warrant PEP, there's a very large shopping list of exposures that may warrant PEP. We did not want to provide the full list, but made the broad statement around bodily fluids and mucosal membranes. And exclusion, we gave examples of the most common exclusion criteria when the index patient is positive from another source, and if the source themselves are HIV negative. And in some settings with high background prevalence of HIV, all eligible exposures may be considered for PEP. So the next set of reviews we did looked at adverse event rates and completion rates from the cohort of observational studies, in which we have over 90 studies that provide information on PEP completion rates, and within those a set of studies from which you can associate completion rates with the use of specific drugs. Again, this is a busy slide. The full evidence will be published in the coming months. But what we can see, if we look firstly at the left-hand side of the presentation, is that you have a relatively low adverse event rate with the tenofovir, raltegravir, and AZT combinations, and a higher discontinuation rate with the use of atazanavir. Dual therapy has lower adverse event rates than triple therapy, but triple therapy using tenofovir and darunavir and raltegravir have lower completion rates than triple therapy using AZT based regimens with protease inhibitors. However, the discontinuation rates due to adverse events do not always translate into lower completion rates. So when we try to assign completion rates by drug regimen, we see that AZT and 3TC is relatively low, despite low completion rates. The tenofovir-based regimens and the raltegravir-based regimens are associated with some of the highest completion rates, and triple therapy has as high a completion rate as dual therapy. So using this information, we determined that a tenofovir-based regimen was a preferred regimen, also considering what we know about tolerability in PrEP and tolerability in antiretroviral therapy. And we recognized also the desirability of using raltegravir as part of a PEP regimen, recognizing high completion rates and low adverse events. However, when the guideline committee went on to make its recommendation, it was cognizant of the fact that currently raltegravir is not widely available in many resource-limited settings. So here is using that evidence, considering feasibility, considering the results of values and preferences, and considering cost, we came up with the following recommendation. So for adults and adolescents, the preferred two-drug I should say beforehand that the guideline panel made a statement that a three-drug regimen is preferred, but a two-drug regimen is acceptable. We're unable to, because we cannot study in a randomized trial the efficacy of PEP, and because the animal studies still are based on very limited data, we unfortunately cannot say anything definitive about whether one should use 3 drugs or 2 drugs for PEP. But considering the increased availability of antiretroviral therapy, the possibility that the exposure source may be harboring drug-resistant HIV, and the alignment with recommendations for treatment, the guideline panel made the statement that a 3-drug regimen is preferred. However, we recognize that in certain situations there may only be 2 drugs available, and we did not want to rule out that as an effective intervention, because there's every likelihood that 2 drugs works very well, from what we know from PEP and from what we know from PrEP and from what we know from PMTCT. So 3 drugs is preferred, 2 drugs is acceptable, and for the first 2 drugs we prefer a tenofovir and 3TC or FTC based regimen, considering alignment with ART and PrEP, and considering the better completion rates and tolerability compared to other regimens. Then for the 3rd drug, we recommend in preference a protease inhibitor, lopinavir ritonavir or atazanavir ritonavir. Of note, we would have liked to have recommended efavirenz to bring the intervention for PEP completely in line with the intervention for treatment. However, there were very, very few studies that gave any information on the use of efavirenz in PEP, and the expert committee were concerned about the difference in the potentially traumatized population who may be exposed to the risk of HIV infection, and the known associated early side effects, CNS side effects associated with efavirenz. So efavirenz was not ruled out, but it was not preferred for that reason. The other drugs we recommend are raltegravir and darunavir. That's because we're aware of that we have data on their use in PEP, but we recognize they're not widely available. It is possible in the future that drugs like dolutegravir and rilpivirine could play a role in PEP, but as of the guideline review meeting, we did not have data on the use of those drugs in PEP, so we were unable to make a recommendation. But we recognize that certain national guidelines are recommending these drugs, and we look forward to evidence being generated so that in future guidance we can consider these drugs. I did not provide all the data for the studies we looked at for children, but we did the same thing. We pooled the evidence we know from observational studies on completion rates and tolerability in order to try and assign preferred regimens for children. But as many of you are aware, we are also limited in the case of pediatric, particularly smaller children of very young age or very low weight, of the available regimens on the market. And so keeping that in mind, again keeping in mind the principle of alignment with treatment, we came up with the recommendation that AZT and 3TC is the preferred backbone, and lopinavir/ritonavir is the preferred third drug. And we gave a series of alternative recommendations that, as long as they are available in age-appropriate formulations, could be considered as potential drugs for PEP. So on to the last part of the guideline and the last part of this presentation. We wanted to look at the way in which PEP was prescribed in order to see whether we could make a recommendation that would improve treatment outcomes. And PEP improve the intervention and reduce the risk of transmission by improving completion rates. The first thing we looked at was the use of partial prescriptions versus full prescriptions. Partial prescriptions are sometimes called starter packs, and as many of you will know, this involves when a potentially eligible individual is in the clinic, you do not give the full 28-day course of PEP. You instead give a 3-day or a 5-day or a 7-day course, and you ask the individual to come back in a week's time in order to prescribe the remainder of the regimen. This is a widespread practice for various reasons. One of the reasons is that there's a belief that during the initial week, one may be able to determine the HIV status of the exposure or the exposed source, and then do a review of the eligibility of PEP a week later. Secondly, there's a view that by asking patients to come back during the course of PEP, one can reinforce adherence. And thirdly, it may be that only a limited amount of drugs are available in emergency wards, and they're prescribed, and the patient can then be referred to a different service for the rest of their medicines. However, when we compared the studies that reported completion rates when the patient was given an initial course of PEP and then a follow-up course, and we compared those studies to studies in which the individual was given 28 days of PEP at initial visit, we found that across all outcomes, the full course of PEP was the better option. There was higher rates of refusal among those offered starter packs compared to full courses, and a higher rate of completion among the full course. And there was very little benefit in terms of stopping during PEP because the exposed was found to be HIV positive or the source was found to be HIV negative, and there was a much higher rate of high rate of defaulting on incomplete treatment. That is to say, individuals who started PEP, only a third of them did not come back after week 1 for the rest of their course of PEP. So those people are known to have defaulted without receiving the full course of PEP. Whereas if you give people 28-day courses of medicine and then they don't show up for further visits, they may or may not still be adherent because they have the full course. So on that basis, we recommend that a full 28-day course should be provided at initial visit. One may still want people to come back to assess toxicity and adherence, but one should give the full course at that initial visit. And the final question we looked at was adherence support. We found 3 randomized trials where each of these trials looked at various forms of enhanced counseling interventions to try and improve adherence and completion rates for PEP. The studies were very small, and that's why 2 of the 3 studies were not statistically significant. When we pooled that information, we found a tendency towards improved completion rates or adherence when enhanced counselling was given. But the guideline panel recognized also that this may come at a cost of increased resources required from services. So this was only made as a conditional recommendation that enhanced adherence counselling is suggested depending on the availability of resources at the clinic level. So with that final recommendation, I would like to acknowledge all the individuals who contributed to the guideline meeting, and I'd like to hand it over to you for any questions that you may have. Thank you for your attention.
Thank you very much, Nathan. I think this is extremely interesting, and I must say that, well, as far as I know, policies around PrEP have been very different, very diverse across the world. And I mean, I can say, for example, in Latin America, in many places, we have had a PEP for occupational exposure. It has been in the guidelines for sexual assault, but probably in very few countries it has been made available for voluntary sexual exposure. And so I guess probably a question I would have, the first question I would have for you is if I mean, you have statistics about the level of recommendation, I mean, the proportion of countries recommending PEP so far for the different kinds of exposure.
Do we have data on the use of PEP by exposure? It's a good question. We do not have that information. WHO does do global surveys on uptake of antiretrovirals for treatment. We haven't been as consistent in asking countries to report data on PEP use, so we don't have that information. There are some studies in the literature that report, so instead of reporting PEP by a particular exposure use, they just report, you know, here is our cohort of all individuals who use PEP in our emergency clinic over the last 2 years. So it would be possible to take those studies and estimate a distribution by exposure, but we did not do that for this guideline.
In fact, my question was, well, I think your response is extremely relevant. It's related to what I asked, but what I had asked is actually the proportion of countries recommending or asking for in their own guidelines for the distribution of PEP in specific exposure situations. I understand that most countries prescribe PEP for occupational exposure, and probably a similar situation for sexual assault, but very few or fewer for voluntary sexual exposure. I mean, and not, I would say, just unsafe sex and seeking PEP just because you realize you had exposed yourself and you want to avoid any potential infection. You know that?
Yes, I understand, and I quite agree that the tradition in many countries has been to have different guidelines for different exposures and to omit to make recommendations for non-occupational exposures. So I do hope that these guidelines will help to promote the idea that PEP should be available to anyone who has an eligible exposure, irrespective of how they were exposed.
Yeah, before I move to a question from the audience, I just make the comment that in many countries it's I mean, involuntary exposure due to occupational circumstances or due to sexual assault are considered circumstances that deserve state-paid access to PEP. But unsafe sex in a context where you just had unsafe sex and you want to prevent potential exposed is considered something that, I mean, a personal risk and something the government doesn't have to deal with. No? So I guess there's a moralistic perspective in many places in relation to that. No? So and that, I mean, if this intervention is available, why not promote it? So probably it's a policy issue that needs to be addressed at some point. But I should move to a question and a follow-up comment from Jill Gay, and this is: what efforts are WHO making to distribute this intervention to gender-based violence services, and collaborating on this with Claudia and Avni at RHR. From Jill, what works for women? Apparently there was a meeting at Open Society Foundation, in Cape Town, and she mentions an example from Tajikistan in 2013, and concern was identified regarding the fact that many places GBV services are completely separate from HIV services.
Yes, thank you for the question, and it's certainly true that PEP is not an intervention only for HIV doctors. It can also be extended to accident and emergency services and other services where PEP should be available and provided. So it is important that the new guidance is going out very, very broadly and not only to HIV program managers. At the global level, we included the sexual and gender-based violence group. So Claudia was part of the guideline review process. And we also included the International Labour Organization and other groups who would want to be promoting, who we would seek their advice in the development of the recommendations and also rely on to promote the recommendations. So at the global level, we have been mindful of that and inclusive. And in the distribution at the national level, we are encouraging WHO staff to reach out to those other services where PEP needs to be provided. But you're quite right to indicate that it's important to be more to think much wider than HIV services if we want to improve PEP uptake.
Yeah. There's a question from Christopher Akolo, and he's asking if there's any update on the risk of drug resistance as it relates to PEP, to PEP.
Yeah, so there's really no evidence in the literature that can inform us around the risk of drug resistance as it relates to PEP and the choice of interventions that one may make as a consequence. Of course, there are two concerns when one speaks of drug resistance. The first is that the source of to which the person is exposed is an HIV drug resistant virus, and therefore the HIV negative individual that receives PEP may receive PEP that may not work because there is drug resistance. And the second is that the HIV negative individual may be poorly adherent to PEP. The second case cannot carries a very, very low risk of development of drug resistance, and if one can prevent infection, then one is okay. In the case of the first instance, we are mindful of that, and this is why the guideline panel preferred 3 drugs over 2 drugs, despite the fact that there is an inconsistency, and it would be interesting to hear other people's views on this. Carlos, maybe you have a view that we recommend 2 drugs for PEP. 2 drugs for PrEP, but 3 drugs for PEP. And I think in many countries, the future will be that PEP and PrEP are seen as 2 sides of the same coin. The US guidelines currently recommend that any individual who is presenting for PEP multiple times, and multiple can mean 2 or 3 times in a year, the health provider should initiate a discussion about whether PrEP would be a good intervention to consider. This is particularly relevant for non-occupational exposures. Now, we were worried about the fact that we were recommending 3 drugs if it's PEP, but 2 drugs if it's PrEP. But nevertheless, in the case of PEP, we felt that for provider simplicity and in order to guard against the small but non-negligible risk of drug resistance, we should stick with 3 drugs. But Carlos, you may have a view on the growing linkage between PEP and PrEP in guidance.
Well, probably I would respond with a question. Among the data you have reviewed, is there any data on the role of adherence in effectiveness? I mean, and especially if people have adhered well for 2 weeks and then they stopped. So if, for example, after 2 weeks there was any effect. I know that there are many variables included. In many cases, you don't know if the source was actually positive. So I understand that these studies are very difficult because there's so much noise, so many uncertainties. But probably besides the 2 key factors that you mentioned, time when PEP is started after exposure, and the type of drugs used, it would be interesting to ask about whether there is a difference in type of exposure and the effectiveness of PEP, also the level of adherence and completion, and also the fluid and membranes involved in exposure. I mean, those 3 factors. There are some other questions, so I will address them, read them later. But if you have anything to add here?
Yes, unfortunately, despite 20 years of using PEP, we have very little systematically assessed information, and we reviewed 93 observational studies. We included any study in which more than 10 individuals were started on PEP, irrespective of exposure, irrespective of age. So we managed to amass a data set of around over 20,000 exposures. But even with this amount of information, it was the largest systematic review I've ever been involved in. But even with this large amount of information, we could not say anything useful to help answer the questions you just raised. They're very important questions. But for example, very few of those studies were able to ascertain with certainty that the exposed individual was not already HIV positive and the source was definitively HIV positive. So if you follow the cohorts through to the end, it's very, very hard to discriminate whether a final HIV positive status was actually due to the exposure and could be linked to one PEP intervention or another. What we do know from the few studies that did have very good ascertainment of HIV status at baseline is that the majority of what one would call PEP failures, so individuals who are known to be at risk, who are known to be HIV negative, and who subsequently seroconverted, we found 38 such cases in the literature, and the vast majority of those cases were continued high-risk exposure post-PEP. So these were individuals for whom they completed PEP, but then they continued to be at high risk of HIV acquisition, and 6 months after the study or 1 year after the study were found to be HIV positive. So the only thing we can say from that information is that it really is a good idea to consider PrEP as an intervention for individuals who continue to remain at high risk exposure.
Mm-hmm. Let's go to the questions from other participants. From Dulce Ferraz. Once we know that PEP, and especially in non-occupational PEP, I think, is underused, are there any recommendations to encourage the search for PEP? And I may add that it also depends on the country regulations. No, if the country allows for this and encourages this, no, and I mean, that's the supply part, and then you have the demand part from people.
Yes. So in order to get the guidance out and make it, because the previous guidance was in 2007, and there was quite an urgent need to update the drug recommendations. We focused this guidance on drugs and with some focus on prescribing of those drugs. What we did not look at was the potential evidence in the upstream, as the question states. How can we find PEP? How can we assess people for eligibility? How can we broaden the attempt to identify people who should be on PEP? I think that's a very important piece of work, and it could well be the subject of future WHO guidance. What we know from the data is that the refusal rates for PEP are quite high. So even when you identify eligible individuals, 10 to 15% of people refuse. We hope that by providing less drugs with less side effects, the eligibility and less cumbersome prescribing practices, we can increase or decrease the refusal rate. But I think it's a very good question. That's a question of service delivery and implementation science, and we will follow up.
About that, what are the main reasons for people declining to take PEP?
So there are some qualitative studies, and there's probably more information than we were able to gather, but we do need to get a better understanding of this. There was a very good study done in South Africa that was published in the British Medical Journal about 6 years ago with female sex workers. I'm sorry, it was victims of sexual assault. So it was a sexual assault clinic, and they listed all the reasons why people declined. And one of the main reasons why people declined was the offer of starter packs. They did not want to be burdened with the requirement to come back to the clinic multiple times. They wanted a one-stop shop where they could get everything they need as soon as possible, and then to only come back if they wanted to, but not as an obligatory, as a formal requirement. And other causes were listed. So it's a specific population. It's it's victims of sexual assault. But I would encourage people to find that article if they're interested.
There's a question from Georgi Veloki from Brazil. How did the researchers measure the completion rate in studies? Probably there's no one single way, but could you say? Yeah.
So obviously, completion rates are can be measured they're measured in the same way as treatment adherence is measured. You can have subjective measures, so self-report or pill count. Are there any pills left after a 28-day course? Some studies went further in trying to assess adherence through 3-day, 5-day, 7-day recall. But the most common way was pill count and self-report. So there can be some question about the correlation between self-reported completion and true high level of adherence, but the PEP literature has very little to say about that.
Yeah, go ahead. Yeah, actually, Georgi is moving forward with another. Taking into account the results to be released about the hypergay trial, is there a possibility to shorten the 28 days treatment?
It's a very good point, and it was brought up at the R4P conference when we made a brief presentation on the PEP recommendation. I think so that information was not able to be considered when we developed these guidelines, but I think we should encourage very imaginative thinking among researchers using the data we have from related interventions to see if we can get a better idea on the maximum duration that is required for PEP to be effective. So I love the question, and I think it's a critical area of future research because the limitations of doing interventions around PEP are very clear and well understood, but that should not mean that we just carry on giving 28 days forever. We should be proactive in trying to interrogate the evidence to see if we can come up with an evidence-based recommendation around shortening the duration, which in turn would maximize completion and adherence.
Mm-hmm. Yeah, I think Jill is asking again. I thought it had kind of been answered, but definitely I can ask that question again. Any guidance on PEP for unsafe sex and morning after regrets? We have Plan B emergency contraception for pregnancy prevention. Mm-hmm.
Well, so the guidelines give very broad definition of what is a at-risk exposure, and they take into account background epidemiology. There should be no, in our view, there should be no judgment around eligibility for PEP. It should be based on a determination of risk. So in a high prevalence setting, unsafe sex, if the source is unknown, could very well be considered an eligibility situation for PEP. So it's not really based on, in our view, on whether a person has unsafe sex or not. It's based on the determination of the risk of HIV acquisition through that exposure.
Mm-hmm. And well, maybe one of the, getting to the end, one question that I think is key here is the I mean, how we get to more people, users and policymakers around the world get to know this, I would say, very important guidelines being released by WHO so that they can translate into local policy. Because I think that's, and one thing is actually people getting to know them, and in some cases also training is required. For example, I think for key populations, very important key population guidelines, integrated guidelines were released last year, but I'm afraid in many countries, more than just the guidance is needed, no? In order for people to organize something that is feasible and useful. No? I don't know how complex it would be to establish PEP. Probably simpler, but still, since we have a few minutes left, maybe you can share with us your thoughts about how to share global guidelines that are, in fact, designed or produced with the collaboration of people around the world, and which are based on both evidence reviews and studies of values and preferences. No? What would you say?
Well, first of all, I would thank you for this webinar, because that is a way to promote the guidance. So thank you very much, and I'd be very happy to do more of this as requests come in. You're quite right that global guidance has to be translated into national guidance, and then national guidance has to be acted on, and these things do not happen automatically. We need to be proactive. WHO in Geneva pushes out the guidance through the medical literature, on the one hand through the scientific conference process, and we did blogs and webinars during the release. We make sure that it goes to all our country offices, and at that point it's to our country officers to try and ensure that the recommendations are translated into national guideline process. I should say that this was clearly a much desired guideline, because during the guideline process we had at least 6 countries writing to us asking for the recommendations as soon as possible, because they were in the process of revising their own guidance. So we sped up the process to try and meet the demands. But we would welcome any other initiatives, and from Geneva level any way in which we can help to promote these recommendations so that they're taken up in national guidance and acted on by providers.
Okay. No, that's very, I mean, and if people can, if we can help, if all, there are other ways of helping, I think will be very important. I think, I mean, there's one last comment, I think, from Jill. Nathan, Carlos, just for you to, well, actually, the Global Fund concept note guidance, and yeah, definitely, I think that's an important point, the issue of how to link with 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 the Global Fund. I happen to sit on the Global Fund Technical Review panel, and definitely that's one place where, I mean, not only the panel but also the committee, but also people writing concept notes. I think that's a very important place where guidance should become broadly not only available but also well understood and sort of incorporated in thinking. Anyway, I think it's been, we have to close already. It's very interesting that you had a kind of shorter presentation than usual, and it allowed for a lot of interaction, which is very, very useful, very positive. So, as I said, we record these presentations, and they will be distributed to our list as soon as this becomes available. For the time being, I really thank you for your presence here today, for speaking to us, and I hope this will help in disseminating PEP, which is so much underutilized. So again, thank you very much, Nathan, and thank you all for being here.
Yes, thank you all for attending, and thanks to you, Carlos, for the